Good afternoon, ladies and gentlemen. I'm Dr. Jia Yichen, and my dear co-chair is Dr. Daijin Yang from Ruan General Hospital in Kaohsiung. It's a great honor for me to introduce the speaker, Dr. Daniel K. Ng. He is the founding president of Asian Pediatric Pulmonology Society, as well as the honorary consultant, Hong Kong Sanatorium and Hospital. He also served as the honorary consultant pediatrician in Guangwan Hospital and the United Christian Hospital. He is the honorary council member of the Hong Kong Society of Pediatric Respirology. Dr. Ng's main research interests are sleep disordered breathing, asthma, and allergic rhinitis. He has published 108 peer-reviewed papers. He is currently the associate editor of Journal of Pediatric Respirology and the Critical Care Medicine and the Respirology Case Report. The topic of his special lecture today is ambulatory pediatrics during ongoing COVID-19 pandemic. Dr. Daniel Ng, please start your talk.
Good afternoon, ladies and gentlemen. Thank you for coming to today's meeting. My name is Daniel Ng, founding president of APPS. I'd like to thank the organizing committee and especially Professor Dan Sang Chung for organizing this excellent congress. And at this time of pandemic, I think it's very appropriate and timely for us to exchange ideas. Today, I'm going to talk about COVID-19 in ambulatory pediatrics. For COVID-19 infection, the incubation period is 5 days, and it's infectious before the onset of symptoms. You usually go through the flu-like illness with fever, sore throat, cough, running nose. Most of the patients will directly move from phase 1 to phase 3 with recovery. A small subset of children will develop critical illness, and that usually start in day 5 to day 7. The excessive immune response leading to a different organ failure, like the respiratory tract ARDS, myocarditis, or DIC. For COVID-19, most of them are in adults. The children only account for 2%, as reported from China and the United States. For children with contact history, and you screen them with a swab, 12% of them will be positive from nasopharyngeal swab or throat swab. And of these 12%, 65% of them will have pneumonia, 20% of common respiratory tract infections, and 16% of them will be asymptomatic. Only 2% of infected children require ICU care. For all children admitted to hospitals, half of them belong to mild severity, 40% belong to moderate severity, 5% belong to severe COVID-19 disease. And of the admitted children, 6.6% of them require ICU care. This line shows the symptomatology of COVID-19 in children. You could see that the commonest clinical features are fever and cough, and followed by URI symptoms like sore throat, pharyngitis, rhinorrhea, fatigue, and malaise, and followed closely by GI symptoms like vomiting, nausea, diarrhea, abdominal pain. Skin rash and anosmia account for a small percentage of children. Looking at children of healthcare workers, this study in the UK screened for COVID infection in 1,000 children. 7% of them turned out to be positive, and the median age is 10 years. Half of this group of children are asymptomatic. The other half has symptoms of fever, GI symptoms, headache, lethargy, change in smell. Change of smell is not uncommon in patients with COVID-19, with either loss or decreased smell or distorted smell. The dysthymia is, of course, more disturbing because you could smell something noxious even when you're smelling perfume. And looking at this group of patients, the rhinorrhea and nasal congestion is actually quite mild. So the suggestion is this smell disorder is in fact neurosensory problems rather than due to conductive problems and due to inflammation of the olfactory neuroepithelium. In Hong Kong, 3 cases were reported. All are teenagers. The first case, a 17-year-old girl. The only feature of COVID is anosmia, lasting for 8 days. The second case is a 15-year-old girl with mild running nose and anosmia again, lasting for 8 days. And last case, a 14-year-old boy with transient anosmia, much shorter time of illness for 3 days. So for COVID-19, divided into mild, moderate, severe, and critical. So the mild case is the common upper respiratory infections. The moderate one is tachypnea with only mild or no insucking. The severe one is tachypnea with moderate severe insucking or hypoxemia. The critical case involves organ failure with ARDS, shock, encephalopathy, myocarditis, DIC, or acute kidney injury. The severe critical case occur more commonly in infants. Up to 11% infants will develop severe critical illness. The risk factor for severe disease are age, the young age, the infancy, and teenagers. They have more than one comorbid conditions, or they have cardiac and neurological disorders, or they have obesity. Multi-system inflammatory syndrome in children is recently described. It's not unlike that of Kawasaki, with high fever of at least 3 days. So it's important not to suppress this sign with regular ibuprofen. And also with the 2 of the following criteria being fulfilled. Number 1 is GI, with vomiting, diarrhea, abdominal pain. The next is non-purulent non-conjunctivitis, skin rash, mucosal changes in the lip or tongue, tachypnea, insucking. Also, you need to exclude other infections before we said this is a multi-system inflammatory syndrome of children. Interestingly, SARS-CoV-2 PCR is often negative, and the diagnosis is based on the IgG being positive. The median age is 10 years, and nearly 44% of them require PICU admission. Management of mild moderate COVID belongs to every expertise of general pediatrics. We should be able to maintain hydration and nutrition, prescribe as needed antibiotic like paracetamol to control the fever and relieve the discomfort. NSAID like Brufen should be used with caution because regular use of it may delay diagnosis of multi-system inflammatory syndrome with the suppression of fever. It will also make the brain tendency worse for undiagnosed thrombocytopenia, which is not uncommon in children with COVID. And also, the animal study has shown that reducing fever may increase the adverse outcome. For SARS-CoV-2 transmissions, looking at about 400 children and adolescents with COVID-19, 70% of them report contact history, and almost all of them have contact history of infected family members. It's important to vaccinate the adults to protect the children who could not be vaccinated, especially for young children. Co-infection is quite common in COVID infection. It's up to 40% in one reported series. The co-infections are usually flu A, B, so it's important to give flu vaccination in the coming season, RSV, and mycoplasma. As we know, severe disease is more common in infants, so one should consider to give azithromycin empirically for infants who develop COVID infection, so as to decrease the chance of hospitalizations, which is very important in the current epidemic because of the paucity of bed availability in many countries. The hospitalization rate is very high in infants, about 15 to 60%. It's much lower in older age group, 4 to 14%, which of course is lower than that in adult, which report as high 30%. Mortality in children much lower, 0.1% compared to 2.3% in adults. For COVID-19, different social measures have been adopted to control the spread. One is the COVID-19 lockdown. Here are some unintended consequences of this. There's evidence of increased depression in children, but not anxiety. And risk factors include loneliness, reduced access to play, or increased access to social media. During this pandemic, almost all children spend their schooling at home, so-called homeschooling. Of course, with this, there will be some biological effect, with increased myopia reported up to 3-fold from China. The lack of social contact, outdoor activities also affect the psychological well-being of children, especially those with special needs, those with parents with mental health problems, or those coming from single or low-income family. To decrease the impact, we should encourage a good sleep hygiene to avoid social media exposure a few hours before sleep onset time, rise in the morning, exercise adequately during the afternoon for an hour or so, and also we should encourage the parent-child interaction with interactive play, playing together with the electronic device, games, or watch the television together. Vaccine is our best hope to control the pandemic, and fortunately, WHO concluded that the BioNTech is suitable for use by children older than 12 years. So it's not uncommon for us to be asked the adverse effect of COVID vaccine. The most worrisome is the myocarditis. It is more commonly reported from male adolescents, young adults, more than 16 years old. And the main reported are the mRNA vaccines, and usually occur after the second dose of it. So the Pfizer Moderna one is reported to have a higher incidence of this myocarditis, and usually occur a few days after vaccination. And up to August 11, 762 cases have been reported. Most of the myocarditis are mild, with only some chest pain, and full recovery are expected or have been reported. So for all vaccinees, we should advise against strenuous activity for 1 week. And there's a speculation that the patients who develop this myocarditis may be inadvertently given IV injection of vaccine when the syringe is inserted in the muscle but not aspirated. So we do not know whether it's in fact intravenous. Because we know that COVID vaccine injected intravenously will cause myocarditis. To diagnose COVID vaccine-related myocarditis, we need appropriate clinical symptoms, i.e. chest discomfort, and then airway myocardial markers with airway troponin T, troponin I, or CK. Also, we also demonstrate the ECG, echo, MI abnormalities before we said this patient has suffered from COVID vaccine-related myocarditis. Herd immunity is important to contain this pandemic. So we need to know the arithmetics. First of all, the reproductive number, basic reproductive number, the R0, which refers to the number of cases infected by one case. And the R0 allows to calculate herd immunity required to contain the pandemic, meaning that the incidence will decrease with time. The threshold is is this formula, R0 minus 1 divided by R0. We know that the new variant, the Delta variant, has much higher infectious rate. One patient infect up to 7 persons. So simple arithmetic, the herd immunity required with 86%. We know vaccine is not 100% effective. The BioNTech has been reported to be effective for 88% of patients, vaccinees. So the vaccination rate required to achieve the 86% herd immunity would be 86% divided by 88%. And that means that we need to vaccinate 98% of the population before reach the threshold to contain the pandemic. So in effect, it means that if the current situation continue, it's very unlikely we contain the pandemic. Because I think in almost all population, 98% vaccination rate is impossible. So we have to decrease the R0, but that allows to have lower vaccination rate to contain the pandemic. So how? Well, COVID vaccine, one of the current problem is COVID vaccine does not produce IgA. Okay? So it will not protect the mucosal cells from being infected by COVID virus. And this asymptomatic infection of the upper airway is very common in children. You could remember that half of the children of healthcare workers are asymptomatic carrier. So it's important to try to eradicate the mucosal infection that is asymptomatic. So here comes the nasal vaccine. A very good example, i.e. the flu vaccine, FluMist. This is a live attenuated co-adapted temperature-sensitive trivalent influenza virus vaccine. It's engineered not to cause disease, and it mimics the natural infections and stimulate production of IgA and IgG. So nasal COVID vaccine is being developed right now, pioneered by Hong Kong U, and they use the live attenuated influenza virus, modify the genes so that the spike protein of SARS-CoV-2 is expressed. It's currently undergo phase 2 trial. Hopefully, we'll have it in a short time, and that will improve the control of asymptomatic infection of the nasal or pharyngeal mucosa. That's in fact the main factor that leads to increase in the basic reproduction number. There's a lot of collateral damage. A lot of patients do not want to go to clinic or hospital now, especially those who are sick because they do not want to get sicker with COVID. So the end result is a lot of chronic disease patients with asthma, diabetes, epilepsy, tech-dependent patients have very high default rates. So someone with a ventilator round the clock or for most of the time of the day, they will be reluctant to go to clinic to have a checkup. So with changes of their conditions, they will not be able to adjust the setting because they have no access to clinical service. Technology-dependent children is defined as more than one technology used to maintain health or well-being. The commonest health tech-dependent children are in fact those on home ventilation for more than 16 hours per day. Even in normal time, the children and the parents may face high stress because of the fact that they are on ventilator. The parents need to keep a close eye on them, and the children also know the problems, their current chest infections, and so on. So with this limited access to medical establishment, that will make the situation much worse. The patient would be, and parents will be very stressed and feel unhappy with the current situation. So here comes telemedicine. As you know, necessity is the mother of all invention. So the patient cannot come to us, we cannot go to them. What do? What we connect by internet, telemedicine. Okay, that is the new norm. To run an efficient telemedicine service, we need good technical support. Okay, audiovisual equipment, internet hooked up at a decent speed. To start the consultation, I think it's no different from a face-to-face clinic consultations. We should introduce ourselves, explain the purpose of this consultation, make sure that we're talking to the right people. So the identity of the carers should be identified, and then we confirm the carers that they are parents with responsibility for the kid. We need to confirm their consent to have this clinical consultation done remotely. So I'd like to present a model of this hospital at home service for home ventilated patients that incorporate the use of telemedicine. So in this model, we have the different team members, okay, that include nurses, technicians, off-site doctors. So what we do is we first, the off-site doctors see a patient remotely and then see the problems. And a team of nurses and technicians goes into the patient's home, assess the patient clinical conditions, check the data from the ventilator, set a monitoring mechanism like the overnight oximetry, overnight transcutaneous CO2 monitoring, or level 3 ESG monitoring. For all this data gathered, then the attending doctors will communicate with the team while the team at the patient's home, and then to decide on the intervention required and see whether the patient tolerates well the intervention. The intervention include adjustment of ventilator setting, the IPAP being inappropriate, appropriate, and so on. The circuit being well done with little ring out. The nurse assess the tracheostomy and gastrostomy. If that's not optimal, then they will try to teach the parents how to optimize care of this stoma site. And also there's many different nursing issues like pressure ulcers, skin rash. The nurse will help the parents to understand the conditions and how to home manage the conditions. Eye care is important. A lot of these patients are neuromuscular, the eyelid cannot be closed properly. So appropriate eye care is very important, not to be missed. And a lot of these patients are on elemental diet, so we need to check the dietary provision to make sure it's adequate. We also find that the psychological problems like depression and anxiety is very common in the parents. We also provide clinical psychological support by clinical psychologists who deliver the service remotely. So far, this program has been done for a year. We have 12 patients. The age is from 4 to 40 years. 8 of them are spinal muscular atrophy, and 4 are other myopathy patients. 4 have been tracheostomized, and 5 are on 24-hour ventilations. We look at the data. An average of 2.5 problems are identified in these 12 patients. And with this team approach, all these problems is either solved or has been improved or lessened. And we ask the parents and the patients, and all we got this service excellent. Well, COVID-19 is obviously a big threat to the normal life of humanities. But there's also other aspects, the benefits of COVID-19. I'm sure you noticed a significant decrease in respiratory admission, and also there's a significant decrease in late preterm delivery. And that's probably related to less pollution, and the mother is getting more rest at home. For respiratory infection, this is interesting data from the US. You could see that the asthma admissions from 2016 and 2019, okay, and while for 2020, it dropped precipitously a week or so after the report COVID-19 pandemics. Okay. So similar data was available from the US, the UK, and Europe. There's nearly 80% reduction in asthma emissions. And also, not surprisingly, respiratory infection also decreased by a huge percentage, 80%. So I think this reduction in infection respiratory tract that leads to a decreased emission for asthma. There's also similar reduction in other respiratory diseases, although the impact on non-respiratory diseases are much less marked. A similar trend of decreased emission for respiratory diseases are also observed in Hong Kong. And looking at the macro factors, we noticed that the NO2 has been reported to have a significant reduction up to 60%. I would like to end with this slide that shows our home, a beautiful Earth, and here are Asia. Asia is a huge expanse of lands, and where hosts the three most populous countries, i.e. China, India, and Indonesia. I think members of APPS are very important to band together to share information, develop programs to cater and protect children of your own countries. We should collaborate, exchange information, promote health practice that ensure well-being of our children. It's important to remember we are one family. Okay? When we share our resources, our information, I'm sure together we'll overcome the current challenge, and tomorrow will be better than today. And in a reasonable time frame, we'll be able to overcome this pandemic and make it manageable. Hopefully, next time we meet in the APPS conference, we can all look back and see how good we have done to bring our community back to a normal level of activities. So with this, I'd like to thank you all for your attention. Thank you.
Okay. Thank you, Professor Wu.
Thank you.
For your wonderful speech. It's really informative and helpful for us. And I am Haijin Yang from the Ruan General Hospital in Kaohsiung City, and I hold this session for our discussion. And I see one question is from our society member by Jenny Lee. Yes, is there any contraindication in using ibuprofen? This is question one. Okay, thank you, doctor.
Yeah, hi. I'm sorry I'm late. And the problem with my connection. For ibuprofen, I think it's very commonly used, especially in the private sector, because of the pressure to control fever. But we know that in animal studies, ibuprofen would increase adverse effect by decreasing the perfusion of the kidney. So if we have equally effective medication like acetaminophen, I think we should not be too eager to suppress all the high temperature and give a false sense of security. So yes, it's safe. It's not unsafe to give ibuprofen, but probably it's safer to give acetaminophen, and there's no extra benefit.
Okay, you. And Professor Wu, there is another question from a society member. His question is, how the insurance company qualify the quality of the telemedicine? Does the laws confines doctor change after telemedicine come out?
I don't know now how the insurance company ensure the quality of doctors, because we bill them, and they sometimes they come back and ask us to clarify, but that's all. They do not really audit our practice. Luckily, I mean, not yet. I'm not sure in Taiwan whether insurance company audit your management and grant around your case, but in Hong Kong we don't. It's just as long as we are reasonable, that's fine. I think that the challenge of telemedicine is that, yes, as you said, the funding model. How do we charge the patients, and how do they get reimbursement? I think that require a trilateral negotiation between the medical care provider, the doctors, the insurance companies, and the parents. I think the law is not very clear on this in Hong Kong, but I think that as long as we practice a reasonable standard, meaning that we establish consent, ideally we saw a patient first before face-to-face, before move on to telemedicine.
Okay, thank you, Professor Ng. And another question from me. Can I ask a question? And do you ever meet any problem during your intervention to the children by the teleconference? Do you ever meet any problems?
I think that, well, luckily have not yet. The problem is mainly the communication. We need to make sure that the logistic of it, meaning the parents can communicate by internet. It's just like me using the WebEx, and I have a problem this morning in the clinic. So I mean, technical support is very important. And next is the communication between a team and a doctor. Let's say I change the iPad setting. They must repeat my instruction. So I make sure they understand my instruction. And then they're going to apply to it to the patients. The other, the miscommunication, the wrong communication is the biggest problem. I remember one time I said increase the iPad to 25. And then I said, okay, maybe perhaps not, we should go down a little bit down to 23 first. But technician already down up to 25. So I think it's important to make sure both sides has a feedback. So he repeat what I said, and I should okay that before he does action. So the communication needs to be double check and would be slower than usual face-to-face communication.
Okay, thank you. There's no other questions from our audience. And okay, due to time limited, we thanks again for Professor Ng for bringing us such a wonderful speech, and looking forward to meet you again in our conference. Okay, yes. Thank you. And let's move forward to the next section. And I have to close this session. Okay. Thank you.
Okay.
Thank you.
Thank you.